A very good day, everyone. I am Dr. Himangi Dubey, Senior Lecturer, Department of Periodontology, BBD University, Lucknow. The topic for the today's lecture is acute gingival infection, in which we'll be discussing about primary herpetic gingivostomatitis and pericoronitis. An acute lesion is of sudden onset and short duration and is painless. They are manifested with severe pain along with systemic manifestation. Thus, these lesions must be treated at the earliest with the proper treatment protocol. Now, coming on to the herpetic gingivostomatitis. Primary herpetic gingivostomatitis is an infection of the oral cavity caused by herpes simplex virus type 1. It occurs most often in the children younger than 6 years of age, but it is also seen in adolescents and adults. It occurs with the equal frequency in males and female patients. In most patients, the primary infection is asymptomatic. As a part of primary infection, the virus ascends through the sensory and autonomic nerves and persists in the neural ganglia that innervates the site as a latent HSV. In approximately 1/3 of the world's population, secondary manifestations result from various stimuli such as sunlight, fever, trauma, stress after oral surgical procedures. The secondary manifestation include herpes labialis, herpes stomatitis, herpes genitalis, ocular herpes, herpetic encephalitis. Secondary herpetic stomatitis can occur as a result of dental treatment and may present as pain away from the site of treatment 2 to 4 days later. Careful inspection for characteristic vesicle may be diagnostic. Here we can see in this figure recurrent herpetic vesicles in the lip early stage and late stage showing brownish crusted lesion. Now coming on to the clinical features, oral signs. Primary herpetic gingivostomatitis appears as a diffuse erythematous shiny involvement of the gingiva and adjacent oral mucosa with varying degree of edema and gingival bleeding. What happens in its initial lesion, it is characterized by the presence of discrete spherical gray vesicles, which may occur on the gingival lingual mucosa and tongue, soft palate, pharynx, sublingual mucosa and tongue. So in this figure, we can see primary herpetic gingivostomatitis in a 12-year-old patient with diffuse erythematous involvement of the gingiva and spherical gray vesicles in the lip. There is a rupture of vesicle and formation of ulcer after 24 hours. Ulcer with small painful red elevated halo-like margins with depressed yellowish gray white central portion. These occurs either in widely separated areas or in cluster where confluence occurs. The course of the disease is limited to 7 to 10 days. Scarring does not occur in the areas of the healed ulceration. Now coming on to the oral symptoms, the disease is accomplished by generalized soreness of the oral cavity, which leads to difficulty while eating and drinking. The ruptured vesicles are the focal sites of pain and are particularly sensitive to touch, thermal changes, food such as condiments and fruit juices, and the action of coarse food. In infants, the disease is marked by irritability and refusal to take food. In these figures, you can see involvement of the lip, gingiva, and tongue in primary herpetic gingivostomatitis. Extraoral and systemic signs and symptoms. Cervical adenitis, fever as 101 degree to 105 degree Fahrenheit, that is 38.3 degrees centigrade to 40.6 degrees centigrade, and generalized malaise is common. Next, coming on to the histopathology, the virus targets the epithelial cells, which shows ballooning degeneration consisting of acantholysis, nuclear clearing, and nuclear enlargement. The cells are called Zhang cells. So after that, what happens is infected cells fuse, forming multinucleated cells, and intercellular edema leads to formation of intraepithelial vesicles. So these intraepithelial vesicles that ruptures and develop a secondary inflammatory response with fibropurulent exudates. Discrete ulceration resulting from rupture of vesicle have a central portion of acute inflammation and exudation surrounded by the zone rich in engorged blood vessels. In this figure, biopsy showing intraepithelial viral vesicles containing fluids and debris with large number of viruses and virally altered epithelial cells. Now coming on to the diagnosis, it is critical to arrive at a diagnosis as early as possible in herpetic infections. Treatment with antiviral medications can dramatically alter the course of the disease, reducing symptoms and potentially reducing recurrence. The diagnosis is usually established from the patient history and the clinical findings. Materials may obtain from the lesions and submitted to the laboratory for confirmatory test, including virus culture and immunologic test using monoclonal antibodies or DNA hybridization technique. Differential diagnosis. Primary herpetic gingival stomatitis should be differentiated from several conditions. NUG can be differentiated in different ways. So here we can see this table. Next, erythema multiforme. Erythema multiforme can be differentiated because its vesicles are generally more extensive than those in primary herpetic gingival stomatitis, and on rupture demonstrated a tendency towards pseudomembrane formation. In addition, जो tongue है that is usually more involved in erythema multiforme with infection of the ruptured vesicle resulting in varying degree of ulceration. Oral involvement जो होता है in erythema multiforme may be accompanied by skin lesions, and the duration of erythema multiforme may be comparable with that of primary herpetic gingival stomatitis, but prolonged involvement may occur for weeks. Steven-Johnson syndrome is a comparatively rare form of EM characterized by hemorrhagic lesion in the oral cavity, hemorrhagic ocular lesions, and bulbous skin lesions. Now, coming on to the bullous lichen planus, it is a very rare and painful condition. It is characterized by large blisters on tongue and cheek that rupture and undergo ulceration. It runs a prolonged, indefinite course. Patches of linear gray race-like lesions of lichen planus are often interseparated among bullous eruptions. Lichen planus involvement of the skin may coexist with the oral lesion and facilitate differential diagnosis. Desquamative gingivitis is a chronic condition and is characterized by diffuse involvement of the gingiva with varying degree of peeling of epithelial surface and exposure of underlying tissues. Recurrent aphthous stomatitis range from small, well-defined, round, shallow ulcers with a yellowish-gray central area surrounded by an erythematous halo. It is of unknown etiology, although immunopathologic mechanism appears to play a role. No diffuse erythematous involvement of the gingiva and no acute toxic symptoms. Previous mucosal ulcers suggest recurrent aphthous stomatitis rather than herpetic gingival stomatitis. Now coming on to the communicability. Primary herpetic gingival stomatitis is contagious. Most adults have developed immunity due to infection during childhood. subclinical infection. Hence, it is seen in infants and children. Recent studies have demonstrated HSV in periodontal pockets suggest more recurrence of viral replication than previously recognized. Now coming on to the next, that is pericoronitis. The term pericoronitis refers to the inflammation of the gingiva in relation to the crown of an incompletely erupted tooth. It occurs most often in mandibular third molar area. In this figure, you can see pericoronitis, that is inflamed coronal flap covering disto-occlusal surface of impacted mandibular third molar. Swelling and redness to be noted. Pericoronitis may be acute, subacute, and chronic. The pathogenesis, the partially erupted or impacted mandibular third molar is the most common site of pericoronitis. The space between the crown of the tooth and the overlying gingival flap is an ideal area for accumulation of food debris and bacterial growth. Acute pericoronitis is identified by varying degree of inflammatory involvement of the pericoronal flap and adjacent structure, as well as by systemic complications. The inflammatory fluid and cellular exudates increases the bulk of the flap, which then may interfere with complete closure of the jaw and can be traumatized by contact with the opposing jaws, aggravating the inflammatory involvement. Next, clinical features. Even in patient who with no clinical signs or symptoms, the gingival flap is chronically inflamed and infected and has varying degree of ulceration on inner surface. Acute inflammatory involvement is a constant possibility and may be exacerbated by trauma, occlusion, or foreign body impaction. The resultant clinical picture of red swollen separating lesion, that is execute, executively tender with radiating pain to ear, throat, floor of the mouth. The patient is extremely uncomfortable because of the foul taste and inability to close the jaw in addition to the pain. Swelling of the cheek in the region of the angle of the jaw and lymphadenitis are common findings. Trismus may also be presenting complaint. The patient may also have systemic complications such as fever, leukocytosis, and malaise. Inflammation complications. Inflammation may be localized in the form of pericoronal abscess. It may spread posteriorly into the oropharyngeal area and medially to the base of the tongue, making it difficult for the patient to swallow. Depending on the severity and extent of the infection, there is involvement of submaxillary, posterior cervical, deep cervical, and retropharyngeal lymph nodes. Peritonsillar abscess, cellulitis, Ludwig's angina are infrequent but potential sequelae of acute pericoronitis. Thank you.